All right, so this is part 2 of the reproductive lecture series. This is the male portion of the lecture. So a lot of programs don't do prostate MRI. Probably a lot of community programs don't do it. And I'd be willing to wager that probably 30% of the people watching this lecture have not seen a prostate MR before, which puts you at a significant disadvantage. So fear not, I'm going to try and cover everything that you need to know about it. It's not that hard. Let's start off with some anatomy. Which line, red, orange, or yellow, represents the apex? You're probably thinking, well, the apex is at the top. That's what that means. We've reached the apex of the mountain. I've reached the apex of my field. That's at the top. And that is what that word usually means, but not for anatomists who study the prostate, apparently. And the way that I remember this is the base is at the base of the bladder, or you can just remember that the people who did the prostate anatomy were a bunch of a-holes, and they got it backwards, so the a-holes put the apex at the bottom. Or you could remember that the apex is near the asshole, and that the A and the A for asshole and apex go together. Or you can just remember the drawing. So you're usually shown prostate anatomy in axial cuts, and it's usually at one of these 3 levels, so it can look a little different depending on the level you're cut through. The important nomenclature is that there are 3 zones. You have a peripheral zone, which is the T2 hyperintense peripheral portion, and then you've got a transitional zone, which is in red here, and a central zone, which is in orange. The ureter runs through the middle, or the urethra runs through the middle. And you'll be able to see that sort of as the little tiny central donut kind of looking thing at all the cuts. Now here's where the trickery starts. A lot of people will lump central zone and transitional zone together into a central gland. And you can imagine that for the purpose of multiple choice, central zone and central gland would make great distractors for each other. So pay attention. I'll just generally say that it's pretty difficult, at least for me, to distinguish between the transitional zone and the central zone. And I think that is probably why people generically use central gland. So this is the central gland, the blue thing, and that's where the BPH nodules live. And this bright part along the outside is the peripheral zone, and that is where most of the cancers live. Like 80%. 70-80%. All right, so let's do a classic case here. This is how prostate cancer is evaluated. If you're making if you've been asked to design a protocol for prostate cancer, you need a couple of different sequences. You need a T2, you need a diffusion with an ADC, you need dynamic contrast imaging with subtractions because they'll use enhancement curves just like in breast MRI. And if the patient has had a biopsy recently, which a lot of them have, you need a T1 to look for hemorrhage. And that's it. Other things, it's typically done with a 3T magnet. It does a lot better than that. Some places will use an endorectal coil, which is just as horrible as it sounds. It's pretty much everything you would need to know about protocoling it. Now let's have a look at this study here. So if you notice, there is a black thing on the right side in the peripheral zone with corresponding low signal on ADC. Now, why don't they show the diffusion? Because the peripheral zone is T2 hyperintense, so you're going to have shine through. And so unless they want to show you both diffusion and ADC, but you just look at the ADC for the dark thing, the diffusion's not that helpful because of how much shine through you're going to have. And then typically post-contrast imaging is shown as a subtraction. So a classic prostate cancer is dark, it's located in the peripheral zone. It's dark on T2, it restricts diffusion, and it enhances on post-contrast imaging. And like I mentioned before, it enhances in a specific pattern, just like breast cancers do. And these are your three different curve types. An uptake with progressive enhancement, an uptake with plateau, or an uptake with washout. And the way to remember that this is the cancer is to think about these curves like you're playing the stock market, which all residents do. With all your extra money as a resident, play the stock market. So I'm sure you're all familiar with the stock market. But the general concept is the best scenario is that you buy stock when it's low, and then it goes up, and it goes up, and it just keeps going up, and up, and up, and up, and up, and up, and more, and more, and more, and more, and more. And when you get tired of making, and when you get tired of winning, you're just so sick of winning, then you sell it, and you retire. You keep working as a radiologist, though, for free, because you love it so much. And then an intermediate thing that would be, you would buy some stock when it was low. It would go up, and then it would just sort of flatten out. You wouldn't lose your money, you just wouldn't make any extra. And then the worst scenario would be, it would go up, but then before you had a chance to sell it, it would rapidly decline, and it would crash, and you would lose all the profit that you made. And so the crashing stock market is like the cancer. All right, so let's look at another one here. So now we're higher up. We're seeing less and less of the T2 hyperintense peripheral zone. If you remember the diagram that I showed where they had the three cuts, one through the top, the middle, and the bottom, this is a cut that's more towards the top because we're not seeing as much of that bright peripheral zone. So what that means is that we're in the central gland, more in the central gland. And cancers look slightly different there. They look more like that. They still restrict diffusion, and they still enhance, but they have more of a smudgy, erased charcoal appearance. So let's look at three different T2 findings. We had our transitional zone tumor in the central gland, which has got this erased charcoal. We've got a peripheral zone lesion, which is dark and it's more discrete. And then we've got these BPH nodules, which are heterogeneous. All these different guys here. You see this pretty much on every single study. That's what they look like. Okay, so just like I try to do this with pretty much every cancer that I talk about, what stage is the quote critical stage? Because, resist the temptation to memorize all staging criteria for everything. You want to instead memorize the stage that's most likely to be asked on the test, and that stage is the one that's going to make a difference clinically and management. And in this case, we've got stage C, which is bulging or frank extracapsular extension. This person has extracapsular extension. And that's one of the things that you're supposed to look for when you interpret prostate MR. The other thing would be, in a really big bad cancer, the neurovascular bundle sits sort of at the corner, right around where this cancer is actually, and that can be invaded by an extended cancer. You could comment on that. The seminal vesicles can be invaded. You could comment on that too. All right, so now we've got a T2 and we've got a post-contrast. And what we're seeing is that we've got these dark things, but they're not enhancing. And this is one of the ways that hemorrhage can be shown. A lot of the patients who get prostate MRs have had previous biopsy, and either the MR is being done for staging, in other words, looking for extracapsular extension, or it's being done because the PSA is continuing to rise, and they are looking for a help with targeting the biopsy, a second biopsy. So it's not uncommon for there to be hemorrhage in the prostate. Now, this can be shown as T1 hyperintense. Blood, just like blood is, subacute blood is lots of places, but that makes it too easy. If I was going to do it, that I wouldn't show you the T1. I would instead show you a nodule that's not enhancing. So it'll be dark on T2, bright on T1, won't enhance, and it can persist for several weeks. All right. That's pretty much it for the prostate. There's really not anything else to know that I can think of. Okay, moving on. So, this what happened to you occasionally in life where you think that something is turning out good, and then it goes horribly, horribly wrong. Horribly, horribly wrong. So, let's talk about some penis anatomy. It's one of my favorite subjects. You may remember from med school anatomy that the penis sort of looks like a monkey's face in cross-section with two blood sacs that are the eyes, and these are the corpus cavernosum. That's the stiff part of the penis. That's the part that engorges and makes your penis usable, deployed for action, ready for combat. And then there's another also blood-fillable sac, the corpus spongiosum, which is less rigid, and it has the urethra that runs through it. And you want it to be more spongy because otherwise it would strangle your urethra off, and you need that to push semen out of, or pee out of, or whatever. So that's, the way functionality, that needs to be a little softer. So why is the corpus cavernosum rigid? Because it has this thick jacket around it called the tunica albuginea, which apparently is white, I guess, based on that name. I don't speak Latin or French, but as we know, those words tend to make good multiple choice test questions. And that is the part that fractures when you fracture your penis. So be careful. It's a dangerous world out there. You don't. It is a dangerous place. So fracture of the tunica albuginea is this guy right here, and that basically defines a fracture of the penis. So let's pretend this is your penis, or my penis, and let's pretend that I've had a history of trauma to it and fractured in the past. What would you expect to be a bad outcome in the future, or is often associated? What is an association with a history of a fractured penis? And that is this. Curvature of the penis results from scarring, as you can imagine. You get a scar basically on that side, which gives you a angled appearance, which, I don't know, might be trendy in Europe, but I imagine creates some dysfunction. Alright, so this is a rug. They used to do these back in the Stone Ages. They still occasionally will in the correct setting of trauma. So a rug stands for retrograde urethrogram, if you haven't seen one before, contrast through the urethra. And it's usually done in the setting of trauma. And there's two main things that they can show on it. So let's think about the classic trauma situation, which is here you are, and then you fall off your bike, and you land on the crossbar, and because of the way your pubic symphysis sits between this crossbar, that you can end up with sort of a cracking, smashing situation where the urethra is damaged, and that creates a focal scar. That is different than the long segment irregular scarring that you can get from a woman of questionable moral standard or a free-spirited woman. So the difference between these two: straddle injury, short segment; gonococcal scarring, long segment. Both can cause narrowed urethra and reproductive issues and also outlet obstruction. All right, so moving on to the testicles. This is a normal variant. It is often seen, but sometimes, so these are two different cases. This is sort of a more mild one here, and this is a little bit more fulminant. If I was going to show you one in a test, I would show you the more fulminant one because it would scare you, and I'd probably, a good trick would be to try to make you think it's a mass and that it would need biopsy or follow-up or something like that, but you see this all the time. It's a common benign finding, and it requires no follow-up. It's sometimes, when I feel like I've seen it more, or when it's bigger and nastier looking, is in the setting of someone who's had a vasectomy, like it's, like there's been some kind of outlet obstruction issue. That may be anecdotal. That's when I've seen it. But the bottom line is, it's benign, it's not uncommon, it's often bilateral, and it requires no intervention. Don't biopsy it. Okay, this is another thing that we see frequently in the scrotum, which is a varicocele, probably seen 10 this week. The important, highly testable point is that they are usually left-sided. And when they're right-sided, or they are non-compressible, like usually they blow up with the valsalva and then they decompress. If they're sort of persistently engorged, then you have to look in the belly. It makes a great next step question. Some modality to look in the belly, because you can have a renal cancer, you can have retroperitoneal fibrosis, you can have nutcracker physiology. There's a bunch of different things that can cause it. Cancer is the one that you want to exclude. All right, another testicle case. This is an Aunt Minnie. It is a uncommon Aunt Minnie, but it is one that has a very, very typical look. You've got this onion-skinned, concentric appearance of a mass in the testicle. It's benign, but here's a practical pearl. Because testicular cancer is way more common than these epidermoid cysts, a painless testicular mass, especially in a young man, is cancer until proven otherwise. If it really looks like an epidermoid, you can say that in your report, and the urologist will probably do a wedge excision with frozen sections rather than a total orchectomy if he's got surge path available and they're in there and they can confirm it. But you can't just call it that based on its appearance and let it go. It has to basically be treated like it's a seminoma. But for the purpose of multiple choice, you can totally call it an epidermoid cyst. But if you get stuck into a next test or next move type of question, it has to go to urology to be treated like it's a cancer. Okay, speaking of cancer, here's a mass, intratesticular mass, and a young man is a cancer. Assuming there's been no history of trauma, things to make you think about trauma would be complex. So when you look at the testicles, just as a general thinking about testicles, there's two big categories. There's intratesticular things and there's extratesticular things. Intratesticular things are usually cancer. Extratesticular things are usually not. like infection, piocele, complex hydroceles, hematoma, those kinds of things. Intratesticular masses there's a lot of different kinds of cancer. So let's talk about that. We've got a young man, 20s and 30s, with a mass in the testicle, intratesticular. 95% of these are going to be germ cell tumors. 5% are going to be sex cord stromal tumors, and we're not even going to talk about those. The germ cell tumors basically come in two categories. They're either seminomas or they're not, and that's about 50-50. And then for older patients, and by older I mean 60s and 70s, you see a mass in the testicle there. That's a lymphoma. Another thing that I want to point out here is that I use this word. Now, anytime race shows up in the header of a multiple choice test question, you need to set off your spider sense that that's being put in there for a reason, because age and race matter for testicular pathology. 90% of testicular cancers are in white people, young white people. Now, older people, the 60-year-olds that get lymphoma, that has no racial preference. So notice I didn't say that he was either white or black or orange or green or whatever here, but I did mention it there, and that was done to help you. So white people get testicular cancer. So here are your three basic choices. You've got a 30-year-old homogeneous mass, seminoma. 30-year-old heterogeneous mass with calcifications, cystic areas, think germ cell, non-seminomatous, think teratoma. Around 60, that's lymphoma. And remember, this can be bilateral. So here are the trivia questions regarding testicular cancers. Where do the Mets drain? Remember embryology, that the testicles descend, right? So the lymphatic drainage is para-aortic and pericaval. So if you were asked where to look next for lymph nodes or whatever, that's where you would look. And who gets testicular cancer? There are family genetic things where that's a risk factor, but the big risk factor is being white and having undescended testicles. And remember also that it's not just the undescended testicle that has an increased risk for malignancy, that the contralateral testicle, even if it's properly descended, has an increased risk for testicular cancer, which makes no sense, but it does. So what about this guy, the microlithiasis guy? Doesn't he have an increased risk for cancer? Well, maybe. It's highly controversial as to whether or not there's a relationship with germ cell tumors. Some people will recommend 6-month follow-ups and then yearly follow-ups. Other people will say just do physical exam. It's extremely unlikely to show up on a test because it's such a controversial issue. Okay, so here's some trickery. 30-year-old African-American male, so I've mentioned both age and race, so that should set off your alarms to think about this. And we can see that he's got multiple hypoechoic masses. But I said that young people, but Prometheus, you say the young people, that the young people, there's only white guys that get testicular cancer. Well, there are 10%. If it's 90% on multiple choice, that means always. So in the real world, yes, African American people 10% of the time are going to get cancers, but with a statistic like 90%, that might as well be always with the purpose of multiple choice. So if you see this picture and an African American, this is going to be mimic, and that's going to be sarcoid. So sarcoid can look a lot like a testicular cancer, but if you're given the demographic that the person is black, or they show you the chest with hyaluradenopathy or a gallium scan, or any other thing that makes you think that this person has sarcoid, then you should have this in the back of your mind. So testicular cancer is for crackers, is the young crackers, is the take-home point. And for you foreign medical grads, cracker is a derogatory term for a white person, but you may also see the word honky used. But let me tell you, you can be a honky and still be hung like a donkey. All right, so that is it for this talk, and the next lecture will be on barium, both upper and lower. I know you've been waiting for that one, but I will tell you, it's going to be the greatest lecture that you've ever seen on barium in the history of the universe.